Hi everybody, my name is Adam Pick and I'd like to welcome you to the webinar titled Advancements in Aortic Valve Surgery with a focus on transcatheter aortic valve implantation, also known as Tabby. If I've yet to meet you, I'm a former aortic valve replacement patient and the founder of HeartValveSurgery.com. The mission of our website is to educate and empower patients with heart valve disease. This webinar, which has had over 150 registrations from patients in countries all over the world, is designed to support that mission. During the webinar, you may have questions. Simply post your questions in the control panel on your screen. We will do our best to address these questions during the Q&A section of the webinar. Lastly, at the end of the webinar, we ask that you complete a quick 5-question survey about this event. Now, I'm thrilled to introduce the featured speakers of this session. Dr. Charles Davidson is the Professor of Medicine and Clinical Chief, Division of Cardiology at Northwestern University Feinberg School of Medicine and Medical Director of the Bloom Cardiovascular Institute. Dr. Davidson has several areas of expertise, including valvular heart disease, coronary angioplasty, and adult congenital heart disease. Dr. Chris Malaisary is an Assistant Professor of Surgery in the Division of Cardiac Surgery at Northwestern University Feinberg School of Medicine and Associate Director, Center for Heart Valve Disease at the Bloom Cardiovascular Institute at Northwestern Memorial Hospital. Dr. Malaisary's clinical interests include aortic valve replacement, bicuspid aortic valve disease, valve-sparing aortic root replacement, and aortic arch reconstruction. By way of disclosures, Dr. Davidson is a consultant to and receives grant support from Edwards Lifesciences. In addition, Dr. Davidson is also a consultant to Direct Flow Medical. Dr. Malaisary is a consultant to and receives grant support from Edwards Lifesciences. And now, without further ado, I'm going to ask Dr. Davidson to begin the Advancements in Aortic Valve Surgery webinar. Dr. Davidson?
Hi, thank you, and I appreciate everybody having the opportunity to take the time out of their busy day to learn some more today about transcatheter aortic valve replacement. This is a relatively new technology, particularly in the United States, where it was just received FDA approval in late 2011. But the first transcatheter heart valve was actually implanted in 1992 in an animal, and the first valve ever implanted in a human was 2002. So really it's in the first 10 years, and the majority of this experience was received in European centers, and then the U.S. began a trial in 2007 sponsored by Edwards, which was investigating the SAPIEN valve, which is the one that is approved currently in the United States. We participated in this trial. The trial was called the Partner Trial to signify the cooperation between cardiologists and cardiac surgeons in evaluating and screening patients for this treatment and also in treating the patients. And as I said, in 2011, it received commercial approval. There are studies still going on in the United States looking at applications of this device to patients that are less high risk, and also applications with newer technologies that are smaller and easier to deliver and safer for the patient. Could I have the next slide, please? So just as a point of overview, the Edwards, what's called the SAPIEN aortic valve, which is a cow valve, is the only commercially available transcatheter, meaning a valve that's placed on a catheter and delivered to the heart without opening up the chest to do that. That is really approved in the United States. There is also another valve that's being investigated in the United States made by Medtronic, which is called the core valve, and this is available only as part of a clinical trial. So the Edwards has two availabilities. One is a larger device that's being used in high-risk and inoperable patients, and then a smaller profile device that we're using in investigational trials now called the Partner 2 trial. Core valve has only investigational use at this point in time and will be available, we anticipate, sometime in 2013. So this is what the valve looks like. It's a cow valve that's actually mounted on a stent, and for those of you that may have had coronary artery treatments. These are the types of stents that are used in the heart, in arteries, and are used in other vessels, like in the carotid arteries or the leg arteries. This type of stent is expanded over a balloon, as you can see in the bottom left and right panel. So it's delivered on a plastic catheter, which can either come up through the femoral artery, through the artery in your groin, and placed across the native aortic valve, with then an inflation of the balloon and pinning of the old valve against the wall of the aorta, and this now becomes the new functioning valve. Or in people who have smaller arteries in their legs and cannot accommodate a valve being placed up through their femoral artery, because these tubes that we use are fairly large. They're about 3 to 4 times the size of a normal catheter that we would use for angiograms or angioplasty. So in those people, and those make up maybe about a third of patients currently, we place this valve through what's called a transapical approach, which is done through a small incision between the ribs, and the same type of delivery catheter, except in a shorter version, is placed up through the apex of the heart, and then the valve is inflated with a balloon and placed over the native aortic valve. The catheter is then withdrawn, and then sutures are placed to close the apex of the heart and allow the heart to continue functioning normally. What's one of the real advantages of this technology is you don't require open heart surgery. You don't require stopping the heart in order for this to happen. This all can be done on a beating heart. We do use, however, general anesthesia in our patients because these procedures can take an hour to 2, and it becomes more comfortable given the extent of the procedure to do this under general anesthesia. There's 2 videos we're going to show, and the first one I'm going to do will be one where it demonstrates placing this from the femoral artery. This is a video that Edwards has put together, and we gave our disclosures beforehand. And then Chris will show you what a transapical placement of this. So here's the cartoon, if you will, of a beating heart, and showing the native aortic valve, which all that white is kind of heavy calcium that causes the valve to restrict its opening over time and cause a disease called aortic stenosis, which then prevents blood from flowing out of the heart into the rest of the body and can cause heart failure, chest pain, or passing out episodes. So as you can see here, we're bringing a wire up into the heart and across the diseased valve, and we curl that wire up into the main pumping chamber of the heart called the left ventricle. From there, a catheter is brought in, a regular balloon catheter, and we expand that balloon across the native valve. And this is really to give us a little working room to place the larger stented valve across the aorta. So that's done, and it's called a balloon valvuloplasty, a technique that we've had for about 20 years, but is not very durable in and of itself. What makes it durable is the placement of these valves on the catheter. So this catheter is now being brought up through the distal aorta. The valve is then being mounted on the balloon inside the body in this version of the valve. And this is actually the investigational version. We then place it across the native aortic valve, the whole catheter with the balloon on it and the stented valve. We inflate the balloon for a period of about 5 seconds, and then this valve immediately becomes the functioning valve within the heart, and the catheter is then withdrawn, and if we're happy with the result, the wire is withdrawn and the procedure is completed with us closing the groin, usually with a couple sutures in the groin, and this again becomes the permanently working valve that has shown very good durability in the initial studies throughout the US and in the 10-year data that we now have available from Europe. Now I think the next slide and the next video will be a transapical positioning of this valve, which Dr. Malazery, our cardiac surgeon who's worked with us on this study as well, and with this implant will describe to you. Chris?
Well, good morning, everybody. It's Chris Malazery here, and welcome everyone to the webinar. Adam, thanks for hosting this webinar for us. We'll go to the next slide right now. Dr. Davidson gave a very nice overview of both the transfemoral, going through the groin, and the transapical, which is going to the tip of the heart approach for this particular valve. Go ahead and play this video, please. So there are different models of this particular valve, but the important point here is that the approach for the transapical is through a small incision in the lower left chest between the ribs. And again, here is a picture of a very tight valve which is causing aortic stenosis. The delivery of the same Edwards valve is done through the tip of the left ventricle, also not using cardiopulmonary bypass or the heart-lung machine, as we call it. And this is done with the heart beating. And the catheters are directly placed into the heart and across the valve with the same concept of using a balloon valvuloplasty to give a little bit more working room. And the valve follows shortly thereafter, going on top of the native valve, essentially making a functional replacement of the aortic valve. So this is a nice perspective of the particular valve we're talking about. This is the Edwards Sapien valve, which is available commercially right now. And I know a lot of people don't have this perspective. Clearly, this valve is on someone's hand, so it's roughly 2 to 3 centimeters in width, and it goes on top of the valve, which is diseased inside the body.
Chris and I showed you a kind of a representation, an artist representation of this, and this is the actual valve being deployed. So this is done under fluoroscopic or X-ray guidance in a typical either what we call a hybrid cath lab or operating room. We have X-rays that are going, and as you can see, this is the balloon inflating and deploying the valve against the native valve, and again becoming now the functioning valve. So this is a typical deployment of an aortic valve in kind of real-time visualization.
So a lot of people ask me what are the advantages of Tabby or TAVR. Both are acceptable acronyms for this particular procedure. Important technical advantages of Tabby is that it's minimally invasive, so it goes through sometimes puncture holes in the groin or very small incisions. And there's no need for cardiopulmonary bypass, what we refer to as the heart-lung machine. Now that leads to some very important advantages for the patient. Reduced recovery time is a big plus for Tabby or TAVR. There's less need for blood transfusions, and there's less incidence of postoperative atrial fibrillation, and that is a fast, irregular heartbeat that happens commonly after heart operations. As with any new technology, some risks are associated with it. Important technical difference that has already been mentioned before with Tabby or TAVR is that the native aortic valve is not actually excised like it is during aortic valve replacement, surgical aortic valve replacement. The second technical difference is that major vessels, particular arteries, are punctured in the groin. So it leads to potential complications of stroke, 2, vascular injury to the vessels that are punctured, and 3, leakiness around the transcatheter valve, which is mostly mild when we do these procedures at Northwestern. Next slide, please. Our clinical experience at Northwestern dates back to 2008 when we first participated in the initial pivotal trials involving transcatheter heart valves. We've implanted approximately 150 heart valves since that time. Currently, we're enrolling intermediate risk patients with aortic stenosis who will need Tabby with second-generation devices, also using the Edwards platform. During the same time, we're also continuing to treat patients who are considered inoperable or very high risk with commercially available valves, which does not require enrollment in a formal trial. Next slide, please. Here's some of our patient success stories. This is one patient who made the newspaper locally here. around Chicago, Illinois. He is a fairly typical patient that we would consider high risk or inoperable. Next slide, please. He made a very quick recovery after his transcatheter aortic valve implantation at the age of 91 and was back home and participating in his daily activities fairly shortly afterwards. Next slide. Another patient we're particularly proud of is Ms. Snyder here, and she was age of 101, underwent a successful transcatheter aortic valve implantation. At that time, she was probably one of the oldest recipients of Tabby. Currently, she's alive and well and almost 104 years old. We're particularly proud of this particular patient. Next slide, please.
So the technology, again, is in evolution, and while it has been highly successful in a large number of patients, there's always room for improvement when we're dealing with first-generation devices, and there are a whole host of companies that have also undertaken development of new devices to try to improve both the deliverability, the successes, and the long-term effects of these. And this is just a bit of a list of those that are either currently in trials, or many of these are actually available in Europe, although not currently available in the United States. Some are under investigation in Europe, and a couple of these will be starting in U.S. trials fairly soon. This is kind of the grocery pictures, if you will, of all the different technologies. The one in the upper left is the one that we showed you, being the Edwards valve. The one in the middle upper is the next one that we should see in this country, which is the core valve device. And then you can see how these others have various designs and iterations that allow for better flexibility, for better sealing around the native valve, and potentially for better both acute and long-term outcomes for our patients, which is really what we're after. So with that, we had time for some questions, and Chris and I would be more than happy to entertain any that you might have.
Yeah, so Dr. Davidson, Dr. Malasry, this is Adam again. Thanks for the clinical insights, and really the patient stories were quite amazing. And I just want to thank you for putting together that section of the presentation. It's really, just personally, it's amazing to learn about the technology you and your teams are working on and the possibilities for enhancement of valvular therapy going forward. As for the questions and answers sections of the presentation, both before and during the webinar, our community of patients and caregivers have been posting questions for you to comment on, and I think we have time here for about 10 or so questions. And the first one comes in from Charlie, who asks, can you share the stroke rates for Tabby? Why are they higher? What is being done to better control that risk?
I can pick up the first. Maybe we'll just alternate questions here, maybe to make it easier. So the stroke risk for TAVR is currently running around 2 to 5% for the acute episode, and there is an accumulation of strokes that occur out to 1 and 2 years. And so when you compare it to surgical aortic valve replacement in high-risk patients, there is a slightly higher risk of stroke if somebody could qualify for both, although the recovery time seems to be the same and the death and outcome is about the same. So what can we do? Again, this is first-generation technology. What are the things that we can do to improve on this, which I think for most of us feels one of the most important complications that we want to get better with? And there's probably 3 things that are going on that are trying to address this. One is the lower profile catheters that will help in delivering the device across the native valve and potentially preventing any of the debris from either the aorta or the native valve being broken off during the procedure. Secondly, there are what we call embolic protection devices that are under development, which will allow us to shield the arteries leading to the brain that can cause a stroke when the valve is being deployed, because most of the strokes are occurring at the time of valve deployment, probably from liberation of calcium off the native valve. So there's one device called Umbrella, there's Transaortic, there's Claret, there's a whole host of these under development and soon to be in U.S. clinical trials. And then the third thing we're looking at is, again, improvements to the actual valve technology and having better sealing of the native valve when the new valve is put in. And some of the newer devices in particular are looking at how do you seal and basically exclude the native valve from the circulation, so the potential for these late strokes may decline as well. And then maybe finally, one last thing, a fourth thing is some of the strokes that we've seen have occurred because of some of the blood thinning medicines that people were being put on after these valves, and we've actually moved back a little bit on the blood thinning medications and not using it as aggressively as we did in the early going, because some of the strokes were actually from bleeding within the brain and not from embolic debris.
Great, thanks, Dr. Davidson. The next question comes from Judy, and she asks, hi Adam, I've already had aortic valve replacement. What is the pipeline for being able to insert a Tabby into a 21 millimeter valve replacement should my valve fail?
So Judy, this is Chris Malasry. So the question is whether or not you can have a Tabby after your aortic valve replacement, and not knowing your particular circumstances, I think that this will be a fantastic option for patients who've had an aortic valve replacement with a tissue valve in the past. So I think that patients who have mechanical valve replacements will not be able to have a Tabby in the future. The patients who've had an aortic valve replacement with a tissue valve, that this technology can be a very good option. And currently we're enrolling patients as we speak for what we call the valve-in-valve procedure, which turns out to be a very feasible, meaning a very doable procedure for patients, and trying to define which group of patients would benefit from this procedure. So yes, Judy, this will be an option for you in the future.
And Dr. Malasry, a follow-up to that question is there are some members of our community who are in the younger demographic who often look to mechanical valves as a one-time replacement for their lives. Do you think that this might alter the course of those patient considerations, considering that you can get a valve-in-valve procedure, or do you think, again, there's still the place for the mechanical valve, this is just going to be one more alternative for patients to consider?
Sure, I think that can change in the decision-making process. Every individual case is different, obviously. But I think for the very young patient, what they have to look forward for with a mechanical valve is that the blood thinning medications will continue to improve. So I think, and as well as many other clinicians feel, that there is going to be other alternatives to Coumadin, which is a blood thinner that is required for a mechanical valve in the future. So there's also improvements in the works for patients with mechanical aortic valves. But certainly, I think patients who are looking at aortic valve replacements who are in their 50s can't decide whether or not they want a mechanical or tissue valve. I think tissue valves become more attractive based on the fact that a new valve procedure when they're in the 70s or 80s can be done with a transcatheter approach, with a Tabby approach.
Great, thank you. The next question comes from Pat, and she writes in, hi Adam, can they repair an ascending aortic aneurysm at the same time as the aortic valve replacement using Tabby?
Chris, go ahead and why don't you take that one?
Yeah, so currently with these devices, only the aortic valve can be treated during the procedure. So the answer is no, ascending aneurysms cannot be repaired at the same time as the Tabby using the stent technology. There's companies looking at this device but they're not even at sort of the beta level testing yet. I think that there could be a combination in the future of a transcatheter valve mounted on existing technology for aneurysmal disease in the abdominal or descending aorta. But currently, these are very experimental and currently under development.
Great. We got an interesting question from Larry, who posted at the blog today, and he wrote, how important is it, the actual numbers of TAVIs performed by a doctor? Is there a steep learning curve for this procedure, and are there likely to be less complications with a more experienced doc?
So that's a great question. There is a learning curve with this technology, as there are with pretty much any new technology, and there have been some guidelines that have been put out by the American College of Cardiology and the Society of Thoracic Surgeons for competency for these procedures and how many previous procedures you maybe need to have done. What this competency surrounds is the experience of the interventional cardiologist in treating patients with valvular and structural disease and having done a number of what we described earlier as balloon valvuloplasties prior to undertaking this treatment. And it also has information in there about the experience of the surgeon having done a certain number of aortic valve replacements. What I think we have been very lucky with and fortunate at Northwestern is having a team of experienced both cardiac surgeons and interventional cardiologists that have done a large number of aortic valve replacements and balloon valvuloplasties and treatment of structural disease before we ever did our first transcatheter aortic valve replacement. And now we've done, I believe, over about 160 of these, and I think we've achieved that level of expertise that the patients should be looking for if they're exploring this technology. Because clearly in the early going there is a learning curve, not just with the technology itself, but the physicians, the team, the nurses, the whole staff that's really part of taking care of these patients that are often sick and have many other medical problems that need to be treated as well.
Great points. And so the next question for Dr. Davidson and Dr. Malessery actually comes from me. As you two may know, I had a bicuspid aortic valve that had severe aortic stenosis and regurgitation. And one of the questions I just had is, TAVI indicated currently for that diagnosis in the high risk or inoperable patient population?
All right, Chris, it's your turn. Why don't you take that?
Yeah, so bicuspid aortic valves were excluded in the trials studying TAVI. So there's limited experience with TAVI with patients with tight aortic valves that are bicuspid. Now, there is increasing experience in Europe with TAVIs going in to patients with bicuspid aortic valves. But again, that's very early and limited. So I think it's, for us, that we look at it as a case-by-case basis. The commercial valve itself does not specifically exclude patients with bicuspid aortic valve, so long as the patients qualify in terms of high risk or inoperability. So I think that, again, an individualized approach is going to be important for patients with bicuspid valves that are stenotic, that are tight.
Great. And so to clarify, I don't know if I heard it correctly, or you may have touched on it earlier in the conversation. Is TAVI applicable to both aortic stenosis and aortic regurgitation, or is it specifically for aortic stenosis?
So right now it is just aortic stenosis and non-bicuspid valves is how it's approved in the United States. Mm-hmm. Many of these new technologies are specifically geared toward being able to also treat aortic regurgitation. So I would say the window of that is somewhere in the 3 to 5 year time range in this country, but clearly that will be an area that will be potentially available for transcatheter aortic valve therapy, assuming that there's not other abnormalities, some of which you asked about earlier, which is aortic root aneurysms that would also need to be treated at the time of valve replacement.
Got it. And the next question is from Robin, and she writes in, I've heard that TAVI is performed with a surgeon and a cardiologist present, just in case something goes wrong during the operation. Is that true? Is it often that the TAVI procedures end up as an open heart procedure?
Go ahead, Chris.
So the procedures are done with both a interventional cardiologist and cardiac surgeon as a team. That does not mean that open heart surgery is done because of that. I think that just a little clarification needs to happen here. I think every TAVI has to be done with an interventional cardiologist and cardiac surgeon present, but that does not necessarily mean that the cardiac surgeon goes ahead and does a standard aortic valve replacement. Adam, am I answering this question correctly? I just understand what she was asking.
Yeah, I think and I'm reading it as best as I can. I think her interest is as to whether or not you and Dr. Davidson may enter into an operation in which TAVI is the objective, but something occurs during the procedure and it ends up converting into a open heart procedure instead. I think that's what she's going after.
You know, I think, and I would add on to what Chris said there, and I think it was a perfect answer, is that, you know, with all cardiac procedures, we always have a multidisciplinary team available. And if there is assistance that's needed for let's say, an angioplasty, we'd want to have a cardiac surgeon available. There's times when the cardiac surgeon would like the interventional cardiologist available. So that I think this is the importance of having a heart team that works on these. And because this technology is in its early stages, is why it's been even more important to have that heart team available at the time of the procedure, participating and making sure that the patients receive the best opportunity for a good outcome.
Great. Moving on, we've got a question from Tanya who wrote in, how long is a TAVI procedure? How does that compare to an open heart procedure?
The TAVI procedure is a shorter procedure than a standard aortic valve replacement, so I would estimate in the operating room or a hybrid operating room or a hybrid cath lab that a TAVI procedure would be roughly 2 hours as compared to 4 hours for a standard aortic valve replacement, meaning in the operating room.
Okay. And one other question, this wasn't specific, we just got a lot of interest about this, and it's been going on for years, is the concept of stem cells being used in the development of tissue for valvular therapy. I know this is a little off topic, but can you provide any developments as to the use of stem cells for something like TAVI or another type of valve replacement in the future?
You know, so this is kind of the holy grail, I suppose, of stem cell therapy. Right now, we're doing actually we have 3 clinical trials going on in Northwestern looking at stem cell therapy, but it's primarily being directed toward people that either have heart muscle damage or inadequate blood flow to the heart that can't be treated by conventional techniques such as angioplasty, stents, or bypass surgery. The growth of new valve tissue is probably further down the line, and while I wouldn't say off the radar screen, it is probably beyond the scope of what we can expect in the near term, as we're still trying to tackle how to get better blood vessel growth into the heart and try to get the heart muscle to try to regenerate rather than growing valves. But it's something to think about. Not sure we're going to see it anytime soon.
Okay, there's one question that came in from Fran, and she's curious to know about the distinctions between patient categories for getting a TAVI. And what she wants to know is, can you please help me understand what it means to be high risk, intermediate risk, and inoperable for a TAVI?
Sure, Fran. So starting with the highest risk group, the inoperable patients. These are patients that, say, for instance, 5 years ago, Tabby did not exist, and you went to see a cardiac surgeon or an interventional cardiologist with aortic stenosis, and your comorbidities were such that both the cardiac surgeon and interventional cardiologist said, well, you would really not benefit from open heart surgery. Then that would be an inoperable patient. And there's certain factors that would make stand out as making patients inoperable. Those are things such as a very calcified aorta, or very, very bad lung disease, or very severe liver disease, or patients who are extremely frail. These are factors that can contribute to inoperability. So that's one group. That's the highest risk group. The group that we consider high risk is actually a little bit easier to define. These are patients that we have an estimated risk of not doing well with surgery, meaning not living 30 days after an aortic valve replacement, of approximately 8%. And it's high risk in that typically an aortic valve replacement can be performed with an operative risk of 1 to 2%, meaning risk of death is 1 to 2%. So any patient with a risk of 8% or more is considered to be high risk. The next group of patients is called the intermediate risk patients, and these are patients who have an operative risk or risk of death of about 4 to 8%. And these risks can be calculated very objectively with a risk calculator. And the final group of patients is the low-risk patients, which are by far the most amount of patients, and those are any group of patients that have a risk of 4% or less. These are low-risk patients.
Great. Thanks, Dr. Malasry. I'm just curious to know offhand, so when you go into a procedure, are these risk profiles, they're calculated well in advance of the procedure, I take it, for every patient? This is done on a routine basis. Is that correct?
So we have go ahead, Chris. Go ahead.
No, that's okay. Yeah, that's correct. We see that preoperatively, and there's a very good risk calculator that is actually, for the web savvy, can be accessed by the patient themselves. It's a little bit nuanced, meaning that you have to know all the definitions of what it means to have peripheral vascular disease and what it means to have chronic lung disease. And but you can actually access it yourself. But those who know how to use it, you can enter in all the comorbidities that you have, and the computer will tell you what your risk is from open heart surgery. Very nice, yeah.
So, look, I maybe want to add one more thing, Adam. We have a valve clinic, which really I think has been instrumental to making sure the patients are directed to the right therapy, because there are more than one treatment options when patients with aortic stenosis come in. One of them may be that it's not severe enough and the medicines are just the right thing right now and it's time to wait a bit. The other might be conventional aortic valve replacement. And the third option might be these transcatheter valves. And so with our multidisciplinary team, we evaluate all of those things, and at that moment we really make an assessment of that risk score that Chris referred to, and we look at other factors that would impact on the patient's ability to do well with any one of these therapies. And so there is an objective and somewhat subjective multidisciplinary assessment of the patient made prior to undertaking any one of these treatment strategies.
Great. And so with this is, I believe this is going to be the final question for the session today. But it's a really good question. It comes in from Steve, and he writes, Adam, in 5 or 10 years, will the advances in Tabby eliminate the need for AVR, aortic valve replacement, for aortic stenosis in all risk categories?
That's a great finishing question, quite honestly. And what we've seen in the early going is using this in kind of high risk and inoperable patients. The trials that we're doing now, the Partner 2 trial, is trying to bring this into that intermediate risk group that Chris described, the people with operative risks somewhere between 4 and 10%. the next step will be to see whether this could be brought into the low-risk group. My own bias at this point, my own opinion, is that the technology is early. Some of the things we talked about, like stroke and vascular complications, need to get better to be competitive with surgery for all populations. If we can do that, there's a good possibility. If we can't do that, then surgery will remain the treatment of choice for the lower risk patients, and really the question is right now in the intermediate risk group patients, which one of the two is superior, and that's what we're trying to study. But it is a terrific question that I think will take five years to really kind of sort out, and may take up to 10 years to sort out.
Great. Dr. Malasry, did you have any comments you wanted to add?
No, I think it was a great finishing statement. Adam, that's a great webinar you had for us. Really appreciate the opportunity to help our patients.
Yeah, well, on behalf of the entire community at HeartValveSurgery.com and all the patients with valve disease all over the world, I'd really like just to extend an extraordinary thank you to both Dr. Davidson and Dr. Malasry for sharing both their valvular and Tabby expertise with us today. I really appreciate it, Dr. Davidson and Dr. Malasry. Thanks so much for being on the call today.
Thank you very much.
Thank you.
And just so everybody knows, there will be a video playback and written transcript of the webinar will be available at HeartValveSurgery.com shortly. And as we end the webinar, I'd like to thank all the attendees for their participation in this special online event and ask that you complete the survey that is about to appear on your screen. And as we always say here, keep on ticking. Thanks so much. Bye-bye.